Great. Hello, everyone. I'm Dr. Mahmarian. I'm the Director of Nuclear Cardiology and Cardiac CT here at Methodist. And today, we're going to talk about some of the basics of nuclear cardiology, mainly for the fellows, so they can get kind of a preemptive look at how we do things in the nuclear lab. So first of all, let's talk about what we image and what we don't image. Alpha particles we don't image because you can basically stop them with a piece of paper. Beta particles, same thing. I mean, it takes nothing to really stop a beta particle. So what we really image is gamma radiation, which penetrates, and as you know, probably the only thing that will stop gamma radiation entirely is lead. And we use that both for SPECT imaging as well as for positron emission PET imaging. We use different radio tracers. With SPECT imaging, we use thallium at times, which is 72 kV, and technetium, which is higher, 140 kV. And we also use, energy like this in CT, ranging from 70 to 140 keV. When you think about radiation in general, you have to think about the relative biologic effect, which is based on the equivalent radiation dose, and that's based on the radioactive emission. So if you look at alpha particles, it's a factor of 20. Basically, there's 20 ionizations for every particle that you get. And this is one of the reasons why alpha radiation is so deadly. In fact, it's been called the assassin's choice in many situations because it doesn't take a lot of alpha particles to really do you in. I think you probably remember a Russian spy several years ago that was killed with alpha radiation in just several days. So alpha radiation is actually quite deadly, whereas beta and gamma only are a factor of 1. And so they're much less dangerous to tissue. And so when we talk about equivalent radiation dose, then we get into effective radiation dose, which is really then based upon those particles and their effect on tissue sensitivity. So some tissue are obviously more sensitive to radiation than others, such as brain, which is very insensitive to radiation, whereas other tissues are much more highly sensitive. When we think about photon interactions, in single photon tomography as well as in positron emission tomography, we're talking about the interactions in tissue, which remember we're injecting a radio tracer, so it has to get out of the body. But there are interactions within tissue for it to get out of the body and to be imaged with either, with a crystal, either in PET imaging or in SPECT imaging. And these emissions are either what we call photoelectric effect, which is where basically you completely absorb a particle and you get an emission, which is usually a scintillation in a crystal, which is a little bit of light that's generated. Or you have scattering, which is Compton scattering, which is also extremely common in tissue, where kind of photons bounce around and lose energy as they go before they ever get out of the body. And of course, then we have positron emission tomography, which is the same thing, but you have less scatter with PET imaging because of the fact that you have a 511 keV photon that is much more likely to exit the body without interacting with tissue. In PET imaging, we have a lot of different tracers that we use. They all have their own separate energy. And if you look at this, for instance, F18 has relatively low energy, whereas rubidium has the highest energy, 3.35 MeV. Now remember, that is the energy of the positron that's being emitted. It is not the 511 keV that's created when you have an annihilation event. So all PET agents annihilate the same way. They all annihilate to 511 keV. But different agents have different positron energies. And those positron energies can also determine how far they travel through space or travel through tissue before they annihilate, which means that lower energy PET agents have better spatial resolution than high energy photons or positrons, which can travel further from where they originate before they annihilate. Remember that we don't image charged particles such as alpha or beta particles, again, because they don't really go very far. But the other issue is that most of the different electron agents that we image are really in CT, because in CT we have ionization effects, and we also have what we call breaking X-rays, where electrons go around the nucleus and slow down, and as matter slows down, it gives off energy. You have to have conservation of energy in matter. And so in CT, that's what we typically image. You know, you have an electron gun or electron emitter that basically then has ionization, where you kick out an electron in a particle, in a molecule, or you have breaking around the nucleus. So different things, different technologies have different ways of imaging. In the photoelectric effect, which is what we really want to do within the crystal of the gamma camera, we have total absorption of energy, and hopefully this photon travels in a straight line. It's absorbed, and it gives off a scintillation, which is a little bit of light, which can then be detected by instrumentation. The other thing we were talking about was scatter, and Compton scatter is very common. And it turns out that the greater the scatter angle, the greater energy that is lost. And to a certain degree, that's to our advantage, because particles that have wide angulations of scatter are particles we do not want to image, because they will degrade your spatial resolution. And one of the important reminders in terms of angle and energy loss is that low energy photons, such as thallium, for instance, which we used to use a lot in the past, lose less energy for any degree of angulation, which means that you can have up to 78-degree angulation and still fit within the window if you have a thallium photon that's being scattered. Whereas with technetium, for instance, you can only have a 54 angle deviation before it would be detected, and for F18 it goes down to 27 degrees. So that's good, because we only want to image photons that have the least amount of scatter. Hopefully we don't image any that are scattered, but we try to image those that have the least amount of scatter, and the higher the energy, the more likely we are not to image those kind of photons if they are scattered. You can also have multiple Compton scatters. You can't it's not just one. Like in the body, you can have a photon scatter in 3 or 4 different places, and hopefully that will lose enough energy where it will either never be emitted from the body, or if it does get emitted, it won't be counted, because it has lost enough energy that it falls outside the window of what we consider an acceptable photon. So when you image anything, whether it be a liver or a heart, there are several basic concepts in terms of what we have in terms of the scintillation cameras. You always have a crystal, and a crystal is what absorbs the photons that come through. In many systems nowadays, we're getting away from this, but in many of the more recent systems that people are still using, we've had lead collimators, which kind of direct which photons are those that we accept. And then we have these things called photomultiplier tubes, which amplify light signals as they come through the crystal. And then this goes to a series of electronics, which kind of shows where in space these photons are originating. And so when you think about different types of imaging, let's just talk a little bit about nuclear imaging. Obviously, we already said we use thallium, which is 72 keV, and technetium, which is 140. PET, you ultimately image 511 keV. With CT, I already said it's 70 to 140, depending on what you choose. And remember that the generation of electromagnetic radiation with CT is very specific. You actually choose your energy and you choose your photon flux depending on your MA. In nuclear cardiac imaging, it isn't that way. It's your emission image, rather than a transmission image, which is CT, the emission image is turned by the radio tracer, which is going to be with technetium 140 kV. But the photon flux, or the amount of photons that you accumulate, are going to be dependent on how much of a dose you give, how many millicuries of an agent you give, and also the amount of time that you image. So the longer you image, the more photons you'll accept, and the better your image quality will be. So there's differences in terms of how different techniques work. CT is a transmission scan, nuclear is an emission scan, but the concepts are very similar, as you can see. Let's talk a little bit about photon interactions with matter. I have lead up here, the sodium iodide crystal, which is a standard crystal, and what we see in soft tissue, which would be in the body. And you can see this diagram looks at where you see photoelectric effect, where you see Compton scattering, and where you see pair production. And so this is 511 kV, this is 140 kV, and the blue arrow is 72 kV. And you can see that for thallium at 72 and for technetium at 140 kV, that obviously lead causes photoelectric effect, but so does the sodium iodide crystal, and that's what you want. You want to get most of your photoelectric effect in that crystal so you can amplify as much light scintillations as you can. But notice that you also see with both thallium and with technetium a lot of Compton scattering, and you see very little photoelectric effect. Okay, so most of what you see in tissue is going to be Compton scattering, and of course that's going to be much more prevalent in radio tracers that have the least amount of energy, such as thallium, as compared to the most amount of energy or the highest energy, such as technetium at 140 kV. So these are all important concepts to remember when you're thinking about a radio tracer to use, and it's one of the reasons why we primarily switched to technetium when it comes to SPECT imaging. The other important issue, or the other important concept, is that of collimation. And if you think about it, when you have emissions, they go about like in a sunburst, like the sun would be. It goes off in all directions, and the farther a photon goes from each other, it splays out at a greater angulation. And the whole idea of photons, of collimators, is to catch those photons that can fit through the lead septi and hit the collimator. So those photons that are most parallel, okay, to the lead are the ones that you really want to image. The rest of those other ones are going to be more scattered photons. And the way we measure resolution is by a point spread function, and what we use is something called the full width half maximum, or the full tenth maximum. And you can see this little diagram where the half maximum is basically the width at 1/2 of the peak value for the spread function. So imagine 2 points in space. And you can see that these are 2 separate points. So remember, when you image a point, every point's going to have a spread function. And it's going to be larger than what you would expect, okay, depending on your collimation, etc. So if you take the full width half maximum, what we see here is that if you look at these 2 points, they would be discernible as 2 separate points because they fit within the full width half maximum, or outside the full width half maximum, okay? And of course, someone is always trying to get me. There we go. All right, but take this example, for instance. Here you have a photopeak, and now you have another photopeak. And look where the full width half maximum is here. So that means that these 2 points are not distinguishable as separate points. because they fall within the full width half maximum, okay? So your full width half maximum is a very important concept. Again, remembering that if you have two separate dots or two separate points, every single one of those is going to have a point spread function. And it's important that to discriminate between those points, that they fit outside the full width half maximum. So how does that work in terms of collimation? So collimators are designed so that the diameter and length of the collimator holes kind of determine the spatial resolution of the system. And you also have the issue of sensitivity, which looks at how many photons can actually get through the lead collimator and hit the crystal. So you might imagine that those are inversely related. The narrower the septi, or the bigger the holes, and the shorter the holes, the more photons that are going to get through to hit the crystal, which are going to increase your sensitivity, but that's going to affect your spatial resolution, because a lot of those photons are going to be bad photons, not parallel photons. So think about it this way: when you look at resolution, as you increase hole diameter, you decrease resolution, but you increase the amount of photons that can get through, so you increase sensitivity. If you increase hole length, you actually increase resolution and you decrease sensitivity, okay? And again, that's because depending on the hole length and the hole diameter, a certain amount of photons are going to be restricted or allowed to get in to hit the crystal to have a scintillation with the crystal. And so we base collimators on different hole widths and diameters. And so you can see here we range from ultra high resolution collimators, which have actually very nice resolution down to about 4 centimeters. But the sensitivity is very low because they let very few photons through, as compared to high sensitivity collimators, which have very poor spatial resolution, but allow a lot of counts to hit, a lot of photons to hit the crystal. So depending on what you are trying to achieve in your imaging, you can use a specific collimator to do so. In nuclear cardiology, we like to use high resolution collimation so that we get the best spatial resolution we can without sacrificing too much sensitivity, or the amount of counts that can get through. So let's look at the issue of distance versus collimators. So here you have a point spread function, and you can see here that as you move the point away from the collimator, that the point spread function widens, which means that your spatial resolution degrades. And that's one of the reasons why when we do cardiac imaging, we try to get the gamma camera face as close to the body as possible so that we keep the point spread function as narrow as possible in terms of being able to discriminate between points. And so the closer you are, the better the spatial resolution. The further away you are from the collimator, the worse the spatial resolution. But look at the bottom grid, and you can see this is going from a low energy collimator to a high energy collimator. And now you can see that even though on the third lower picture that point is still as far as it was in the middle one, that the point spread function is very narrow because you have more septi, you have very, very small holes and longer lead septi, so that very few of bad photons get through. Okay? So these are ways in which you can change what your spatial resolution is going to be based on the type of collimator you use and how close or how far you are from the collimator surface when you image someone. So for all types of collimation, resolution degrades as the object is moved away from the collimator surface. And I think that's one of the reasons, again, why it's so important to try to image patients as close to to the body as possible to improve that particular aspect. All right, and again, this shows the same thing, that as you, in a more graphic way, as you move the collimator away from the patient, that the point spread function gets wider and wider, and therefore your spatial resolution gets more degraded over time. All right, let's talk a little bit about detectors. Obviously, we talked a little bit about sodium iodide crystals. We also had photomultiplier tubes that amplify scintillations once they are emitted by the crystals. We have voltage discriminators, which tell us what kind of energy is being actually captured in the crystal. And then we have the display devices. There's also the concept of how much thickness you need of a crystal to really get optimal absorption, photoelectric effect in terms of scintillations versus, versus thin versus thick. And you can see that for the 140 kV photon of technetium, that there's an optimal thickness for sodium iodide crystals where you max out the amount of detection or sensitivity you can achieve without having just photons go right through or not being captured at all, okay? And so there's an optimal thickness for all kinds of crystals. We talked a little bit about the voltage amplifiers or the voltage discriminators that we see. So let's say you have, 5 or 6 photons get through from the crystal into the electronics. The question is, what is the energy of those particles? And what we want is, if we have a 140 kV photon of technetium, we don't want to image a photon with 80 kV. Okay? And that's where the energy discriminator helps tell us what are good photons and what are bad photons. Okay? And so you can see there's checks and balances all throughout this whole process to try to only get the good photons, from collimation to using energy discrimination, etc., to try to get only those photons which will make the best pictures and improve your spatial resolution. And so the pulse height analyzer looks at all of this, and obviously that blue area is where we really want to be on either side of the 140 kV photon of technetium, with a 10% window. And the rest of it, we don't want to image, okay? And we have to remember that a lot of these different photons will get through to the gamma camera face, to the crystal itself, even though they may have been scattered in the body. And we can have multiple types of scattering. I already told you that we can have multiple Compton scatters within the body where you still have enough energy to get into the crystal and be recorded. But let's say you have a technetium photon that's been scattered 3 times, and you still have an energy of, and now you have an energy of 80 kV. Well, the energy discriminator will now tell you that that photon is not acceptable, okay? And it will not count it as one that should be registered in the image. And so this is kind of just a graphic look at all the different types of scattering you may see. Obviously, the more scattered the photon, like the Compton 4th order scatters, the less energy they have. And you can see in the blue area, again, the kind of photons we want to accept. And this is determined by determining the energy of that photon that's been accepted by the crystal, but maybe you don't want to accept in your image because the energy is too low. So some of the advances in SPECT imaging over the years, the objectives have been to reduce imaging time, increase sensitivity, or how many counts we have, improve energy discrimination, improve spatial resolution, and reduce radiation exposure. There's been a lot of systems out there. One of the nicest ones out there right now is the Spectrum Dynamics camera. It's a CZT camera. And the nice thing about CZT is that you directly accept photons and into electrical impulses, which are registered. And so you do not have photomultiplier tubes. And so you have direct conversion of scintillations into electrical current. And in fact, that in many respects, based on the kind of crystal you're using, the CZT crystal, and the way the septi are arranged, in that the spatial resolution is better, but you also get higher counts. And that higher counts has actually been more recently looked at in terms of being able to look at, as we do in PET imaging, looking at myocardial blood flow measurements. And so there is the potential for looking at myocardial blood flow with SPECT imaging as we do with PET imaging using technesium rather than a positron emitter like rubidium, by being able to accept enough counts where you can actually measure blood flow through the myocardium as it rapidly passes, which up until now has been very difficult with the kind of electronics and the kind of crystal acceptance rate we have in terms of photons. And again, CZT is becoming more or less the standard now for how we can image patients with SPECT imaging. And the nice thing about CZT is also that it has better energy discrimination than sodium iodide crystals, which again means better spatial resolution, because you're only going to accept those photons that are extremely close to the 140 kV of technetium, which you're using as your radio tracer. Okay, so now let's go to the next step in terms of image reconstruction. Now, image reconstruction uses filtered back projection, and this is not an unusual concept. For instance, we use it in nuclear cardiology, but it's also used in CT, filtered back projection, in terms of being able to get a three-dimensional image. And the way this works is, you can see here, if you just have one view of a photon going through space, you can see you really can't see much of any image. If you take 2 views, it gets a little bit better. You take 4 views, you're starting to see something. 8 views, now you're starting to see where those photons are accumulating in one particular area. And so it's through filtered back projection that we're able to create a three-dimensional image. And the nice thing about this is that we use wide spectrum cameras over 180 degrees, which allow us to look at the myocardium over that entire area. And so if I look at any of you from one angle, I'll see something different. But if I go to another angle, I'll see, again, a different perspective. And that's what this basically does. It looks at a different perspective of the myocardium as you look at across that 180-degree array and create your three-dimensional image. Now, another concept that's very important is filtering. And we can filter as much as we want until we just see nothing but a blur. But so we have to have sort of a balance between how much filtering we do, how much high frequencies we take out, how much low frequencies we keep, etc. And obviously, high frequencies represent very steep things like edges, and low frequencies are like a flat tabletop would be before you get to the edge, which would be a high frequency change, okay? And so if we look at different images, we'll take this for instance. This is a photograph where it's been manipulated. There's the original image. If we start removing high frequencies as you go from left to right and then to the bottom images, you can see finally, by removing all except the low frequencies, we have no image left at all. It's just one big blur. So we don't want that when we image the heart. I guess we just call everything normal and be done with it. But we need to be able to see, detail. And the way you keep detail is to keep at least a certain amount of high frequency information. The other issue is what you're looking at when you look at a screen, because resolution is really based on pixels and the number of pixels you have per certain amount of area, right? And so if you take the image above and look at 320 by 250 pixels, that's pretty good discrimination of the edges in that particular landmark. But if you go to 43 by 34 pixels, you can see you can hardly determine anything, right? Because everything is blurred. And so even when we think about how we reconstruct an image or look at an image on a monitor, it's really going to be very dependent on what the number of pixels we have per a certain amount of area to really maximize our visual resolution of the image. Okay? Remember, all of these images have an intrinsic spatial resolution based on the dynamics or the construction of your imaging technique. But the image resolution that you see on your screen is also based on what you're actually looking at. And that's why in cardiac imaging, we like to get the best imaging, the best imaging equipment as possible that has the best image resolution, so we can appreciate and take the opportunity to see images more clearly. So it always gets in again to how much do you filter, and it's just important to remember that all filters remove information. The optimal filter is always subjective. It's determined by the amount of photons that you actually accept within an image, which can lead to more or less noise and the resolution of the system. But that over-filtering really leaves you with no useful information. And so we use different filter cutoffs, and you can see that in this particular image on the left, we basically have an unfiltered image. And as you can see, as we go from left to right, that we've taken out more and more high frequencies, and you can see that the image becomes more and more blurred. And somewhere in between there is going to be an optimal view of an image in terms of what we would like to see pleasing when we interpret. The other issue, and why it's so important, why sensitivity, crystal sensitivity, and why the number of photons you acquire is so important, is because of the issue of noise. So noise is determined by the square root of the number of counts that you have. So if you have a low amount of counts, you're going to have a lot of noise. If you have a high number of counts, you're going to dramatically reduce your noise in your image. And that's why, like I said, you can do one of two things when you do SPECT imaging. You can give a higher dose of radiopharmaceutical, a higher dose of millicuries, so you get more counts that way, or you can image the patient per stop longer to get more counts per image, so that you do not degrade your image and have a lot of noise. Because then if you have a lot of noise, you're going to have to overfilter. And overfiltering is not what we want to do. We would like to use the least amount of filtering possible to keep the high resolution information available, but also to reduce any very noisy images that it would be difficult to interpret. So again, when it comes to KV and image quality, what we want to really do is we want to have less Compton scatter, so we want higher energy photons, and we want to image longer or give more millicuries when we're doing things, so we get more image information. Because the counts are really where the image information is. The KV is simply the way to get there, okay, and to be accepted by the crystal. Okay, what about uniformity? every gamma camera has what we call some areas of non-uniformity. And so we look at gamma camera uniformity, we look at spatial resolution and linearity, and center of rotation. Uniformity refers to the ability of a gamma camera to display a uniform response to radiation over its entire field of view. And we look at integral uniformity and differential uniformity. Integral uniformity is over the entire crystal of the gamma camera. Differential uniformity is in regional areas. And we try to keep uniformity at a minimal. And so if you look at this particular image, you can see the one on the top, the uniformity was 4.7 in terms of the central field of view. But if you look at the uniformity on the bottom, you can see how blotchy that image is. And that's very bad uniformity. It's over 10%. And so every day we measure uniformity on our systems and correct for any non-uniformity by flooding the cameras and being able to make sure that, that they're responding adequately. Okay, we also, like I said, we do intrinsic and extrinsic measurements. Intrinsic measurements are without the collimator, and that's when we look at basically the instrumentation and the sodium iodide crystal and etc., or the CZT crystal, and see how they are responding, and hopefully they're responding adequately. Or we do extrinsic measurements with the collimator to also look at their performance. Non-uniformity can be done to a lot of different things. Crystal damage, PM tube failure, improper coupling of the PM tube to the crystal, incorrect application of correction maps, incorrect energy resolution, and electronics that have failed. Hopefully we don't have any of that. If we do, it has to be taken care of, and obviously patients wouldn't be imaged with a uniformity that's not adequate. Spatial resolution and linearity is another concept. We don't have to worry about this with CZT crystals because we don't have PM tubes, but in cameras that do have PM tubes, and many of them out there still do, we have to remember that linearity is a reflection of what is going as an input function of light as compared to what's an output function of light. And there's going to be differential in terms of the output function with greater signal toward the periphery of the PM tube rather than the central area of the PM tube. And that obviously needs correction. And the way we look at spatial resolution is using bars, phantoms, and we try to see what we can discern in terms of what the smallest line we can discern between two lines, the space between two lines. And that gives us a reflection of our spatial resolution. Center rotation is another concept. This is mostly on rotating gamma cameras, where you can get deviation in terms of axis of rotation. And if there's axis of rotation errors, you can create perfusion abnormalities. So you can see the middle one is one where there's 0 pixels of rotation error, and where on the left and the right, you can see where there's 1.5 pixels of rotation error, and you can see you created a septal defect on the left, and you created a lateral defect on the right due to a rotation error. So it's very important to keep that in mind. When we think about artifacts in SPECT imaging, there are multiple things we need to be aware of. We need to think about vertical motion. We need to think about horizontal motion. We need to see what the distribution of a radio tracer is. I mean, do we have adequate counts? Was there infiltration of the dose? Is there extra cardiac involvement or interference from gut, which is a common problem with technetium because of excretion of technetium in the liver. Contamination from other areas or areas of abnormal uptake, like you would with masses or anything else in the body, or attenuation artifacts. So this is looking at motion. This is a patient on the top with motion, and this is after motion correction. And remember that motion artifacts can hide or create perfusion abnormalities. So it's not like they always create them. They can always hide. They can also hide them because of blurring from the motion artifacts. And so it's very important that we try to avoid motion. And you know, most systems nowadays have motion correction algorithms. But frankly, whether you look at nuclear cardiac imaging or you look at CT imaging, where it's problematic many times, motion correction is best corrected by not having motion. And so, you know, the algorithms are great, but the most important thing is to make sure that people stay still when they're being imaged and that there is no motion, because that's the best way to avoid artifacts on a nuclear image. This is just another example of someone who you can see here has a lateral defect on the upper images, but on the lower images it goes away. This patient was re-imaged. This patient had a lot of motion artifacts on the top image, and on the second set of images where he was not moving, it's a normal study. So it's just very important to, you know, if on SPECT imaging, if someone moves, we simply repeat the images if there's a lot of excess motion. Another type of attenuation that we commonly see in nuclear imaging is breast attenuation. Obviously, you know, this is because of soft tissue from the breasts. And usually it involves the anterior and anterolateral walls, but basically depending on wherever the size of the breasts are, it can affect any part of the heart. And this is an example, for instance, of a variable breast attenuation artifact where someone was imaged with the breasts in one position on one scan, on the stress scan, and the breast covers the entire heart on the rest scan. And so it looks like there's a perfusion abnormality, but it's not really true. It's just attenuation artifacts. So it's really just important to keep that in mind. One of the ways in which we get around this now in terms of breast attenuation is obviously using CT correction. And a lot of the systems nowadays, including our own, have CT corrected images which allow us to take this into consideration. Another thing you can do is prone imaging, and we routinely do prone imaging on our patients where we don't have CT imaging if the initial images are suspect for attenuation artifacts. And so this is just an example of a patient, again, where, you know, there was breast attenuation on the stress images, but not on the rest images. It called ischemia, and the patient had a completely normal CT, which was totally avoidable if we had just re-imaged or had CT or prone imaging to look at that patient. Diaphragmatic attenuation is another culprit that's seen in almost every single SPECT image you look at to a certain degree. Again, this is something that can be avoided by doing either prone imaging or CT correction. This is just an example of, you can see how the inferior and posterior walls are markedly reduced in count density because of diaphragmatic attenuation. And then we have also the other issues of adjacent hot structures, such as liver, stomach, and bowel, which can do several things. They can contribute counts to where you would have ordinarily caused a perfusion defect, or they can obscure walls by overlying a perfusion defect, or they can actually create perfusion abnormalities. So it's best not to have subdiaphragmatic count activity on your images. And again, if there is a lot on any given image on a SPECT study, we like to re-image the patient to try to avoid that. This is an example of someone with marked subdiaphragmatic count activity where you know, this has been markedly degraded because of that. And you know, we already talked a little bit about filtered back projection, and the ramp filter is one of the ones that we use to do filtered back projection. which automatically can leave artifacts, perfusion abnormalities. And so most of the imaging that's done today still does filtered back projection, obviously, but does iterative reconstruction on images to avoid that kind of problem. So this is an example of a ramp filter artifact where on the upper images, the image was reconstructed as typical filter back projection, ramp filter. And on the second set of images right underneath, this is still filter back projection, but now with iterative reconstruction, avoiding using the ramp filter. And you can see there's no perfusion abnormality anymore. So that kind of gives you a view of where we sit with image acquisition in nuclear cardiac imaging. Dr. Al-Mallah, who's in the back there, will talk more about PET imaging. This is mainly dealt with SPECT, with also some discussion of PET imaging as well. But you know, there are so many things beyond just image acquisition alone, which is extremely important, and all of this information is extremely important for you to be aware of, because this is all, these are all things that happen behind the scenes, you know, while you're sitting there in the reading room. All of this is going on in terms of imaging and image reconstruction, etc. And you need to be aware of all of the pitfalls that you can see in imaging before you can ever interpret an image. So now that you have that behind you, the next sets of lectures will be stressor modalities, interpretation, and how all of this is clinically relevant. Thank you very much. Are there any questions? I know it's a lot of information in a short period of time. All right, very good. Thank you.